Well, and in some cases, it seems there's some low-hanging fruit that can be exploited as well. Dr. Mark Fendrick, who is co-editor of the American Journal of Managed Care, of course, we know is very big on value-based insurance design. And it's my understanding that, for example, while the ACA covers preventive care as part of a mandate, if you look at health savings accounts, some of the other things like value-based insurance design for chronic illness care, for lancets and for drugs and for test strips and things can't be covered because of IRS rules. So in any of this legislation, when it's rolled out, there's always ways in which things can be improved. But I think earlier, Ateev, you were really alluding to, I think, essentially VBID type principles and thinking about benefit design that might be more rational for at least helping consumers to make good choices about the type of care that they get. So in essence, maybe not all care is valued equally in terms of its health producing effects, and we need a more flexible insurance design to help accomplish that.
I think that makes a ton of sense to me, that, that we would try to waive the co-payments for diabetes medications, waive the co-payments and have no out-of-pocket costs for certain things that we know are really critical. We already know compliance with medications is really low, and we need to make it as easy as possible for patients to do so. I don't want to deny there's a lot of complexity there. You know, as some of the work that some of my colleagues have done on consumer-directed health plans. So in consumer-directed health plan, we know that preventive care, or preventive care for everybody now, is patients don't have to pay out of pocket for it. But we see a decrease in the use of preventive care. And I think the truth is that a lot of consumers don't know, or people with a health plan know the complexity of their design and that certain things are covered and certain things are not covered. And with VBID, I think that's another critical issue, that, you know, insurance design is so complicated. I'm a health policy expert, but when I get that sheet, you know, for my own health insurance design, it's pretty confusing. And so I think that's the part that I get worried about. I don't have a great solution for that, but just acknowledge that is an issue.
Mm-hmm. So, if, you know, I'm not an actuary, but if I think like one, or at least attempt to think like one, it seems like this trade-off between limited network versus high deductible and sort of choice, you know, actuarially, this may make a difference. You know, in other words, if we can convince the population that a narrow network might be composed of high-quality providers, and if we can leverage that in the marketplace in negotiations, then maybe that may be a vehicle for thinking about reducing costs. But, you know, I guess the question is there that leverage in the marketplace to make that happen?
Well, I think it has to. I think it has to. And again, to bring down costs, whether it's a high deductible plan where the burden is on the individual consumer and them making educated choices and bringing down costs, or whether it's with an ACO or a system where the burden is on the system to do that, it's really out there to accomplish the same thing.
You know, one point I'd make, Dennis, is, and I'm not an actuary either, but last year we hired some actuaries to help us develop a couple of models, a little bit, as you mentioned, Ateev, because the concern that the actuaries have around these high deductible health plans and eroding what has been, in their minds, gained because you're shifting a certain percentage of cost up front to the individual plan member, is that if you change that, then you move from a certain environment in which you know that of the total premium or per capita cost for an individual, $1,500, $2,000 is taken care of, and so you're only worried as the insurer with the balance. And if you can then enter into either narrow networks or other arrangements, you can shift another portion of it and makes the total cost predictable. So if you flip that on its head and you say, I'm going to give you a medical spending allowance for a particular condition, a set of conditions, or for particular treatment and options, and you create the dollar sensitivity at the marginal dollar, what would happen? And can you find a way to make it actuarially equivalent to the models that exist today? And the short answer is yes, because you can set your medical episode spending allowance pretty much at any level you want. So if you currently have, let's say, take a patient who has multiple chronic conditions, and maybe their annual spend is, for the combination is $15,000, and they're paying $1,500 out of that by themselves. Well, if you created a medical spending allowance at $8,500, actuarially it's equivalent, because they would be paying on top of the $8,500, and so net for the plan, you end up with the same thing. But the point is, the Lancet's, the ongoing secondary prevention for that patient, going to the physician, your appropriate medication, all of that ends up by being paid for first dollar as opposed to after the deductible is met. And we know from Mark's studies and others that compliance obviously goes up. So I think there is a way, and we spent a fair amount of time looking into this and developing some actuarial models that actually show that if you engage in the type of arbitrage that you mentioned, Ateev, where you give people a certain number and then they have options and they can look at how those options play out in the delivery system, whether you push them towards a narrow network or a set of options, you can impact PMPM by several basis points in a positive way for the plan, which means decreased total trend. So there is a way, I think, of looking at benefit design in a far different manner than we have in the past, and create sensitivity for cost where it should be, as opposed to where it shouldn't.
Mm-hmm. And we're looking right now at a snapshot in time that is right now. And it's going to make sense to make some changes that are logical, will save money. I mean, let's say we took a snapshot in time 2 or 3 years ago. We didn't have coverage stage 26. We didn't have annual limits, lifetime limits. So there are still things that need to be changed. The whole ACA and delivery system, there's evolution going on, and I'm convinced we're going in the right direction, but clearly there are a lot of things that do still need to be changed.
Sure. Talking about benefit design, let's talk a little bit about pharmacy benefit design as well. We talked earlier about new drugs like Sovaldi and others. Is there any silver bullet or any approach that seems to be working in terms of thinking about benefit design on the pharmacy side? And also it would seem that it's important to make sure that pharmacy benefit design sort of integrates or coordinates with incentives on the care delivery side as well.
Well, a cottage industry has developed over this very subject, and even they are being challenged by this. But what do you do with somebody who has a medication that costs $85,000 a year, $100,000 a year? I saw one recently, $450,000 a year for somebody treated for one condition. What do you do? And they're responsible for 20% of those costs? You can't do that. You just can't. So it is a challenge. So what you want to do is, where there is truly a generic, you want patients steered over to the generic. And it's really important that the doctors, the mid-levels, and the patients all have a discussion that those generics are okay. We have seen by public relations and advertising and just reaching, we've seen the fill rate in generics go up from about 45% almost to 70% in upstate New York, saving literally billions of dollars. So, but then, as I said earlier, you got to keep an eye on to, okay, so once those generics are ordered a lot, can that generic producing company increase the cost? No, they can't. But you have to keep an eye on that. And then with a tiered system, first and foremost, what are the medications that are effective? What is going to work? But you also do have to put cost into the formula, which we've always been reluctant to do in the past. But as some of these medications are becoming incredibly expensive and used for many, many years, it's a challenge.